All right, let's talk about anticonvulsant drugs. So we'll start off with some terminology. We have idiopathic epilepsy. It's, of course, epilepsy with an unknown cause. We have status epilepticus, which is the act of having a seizure, and it's often repeating. We have preictal phase, which is a phase that indicates that a seizure is about to happen. And animals will often seek out their owners or engage in sort of comfort-seeking behavior. Ictus is the seizure itself. Generalized seizure is a seizure affecting the entire brain and body. Focal seizure is a partial seizure, often no postictal phase. Postictal phase is the time after the seizure has occurred, and convulsions are seizures that manifest themselves as spastic muscle movement, caused by stimulation of motor nerves in the brain or spinal cord. Some seizures do not involve convulsions, so especially focal seizures don't involve convulsions. So we're going to have a look here at this guy who's undergoing a focal seizure. So remember that focal seizures, it's a seizure, tons of neurons are just firing like crazy. And a focal seizure, it's happening in certain parts of his brain, his or her brain. So he's not having full-blown convulsions. He's just having the shakes and small tremors. Oops. And then next up we have, this is the postictal phase. So this is the phase where the animal's just had a seizure and they're not quite themselves yet. They're not quite sure what's going on. And I believe this is the video, if I play it all the way through, that you'll see him sort of being out of it and then sort of coming back to normal. Now, super important to note that during the postictal phase, most owners want to run and comfort their dog or cat. But it's really important at this phase that they just give them a safe place and kind of are hands off, because this is the phase where a lot of owners get bitten because the dog hasn't quite come back to who they normally are. So it can be really scary for the dog, and they're sort of in this phase of instinct rather than themselves. Oh, what happened? Oh God, that was weird. So I always picture them saying, "Oh God, where was I?" So poor little dog. It's not funny. It's so sad when they go through this. Seizures are really challenging to watch. They're desperately sad. In that moment, there's not much that you can do unless you have medication, other than keep them safe and, keep yourself out of harm's way as well with your animal. So looking at epilepsy versus other cause of seizures, seizures of epilepsy, most are not life-threatening. If they're from unknown origin, such as a toxin or an injury, then those ones definitely can be a challenge to maintain. Issues with seizures, if animals keep going into seizures and they continuously have convulsions, then very quickly they get at risk of hyperthermia, because you can imagine their neurons are firing like crazy and all their muscle cells are firing like crazy to create these convulsions. So of course, with muscles constantly in use, then we're going to get hyperthermia. Likewise with hypoxia, because oftentimes they're not breathing appropriately and the blood flow is shunted to specific areas of their body. And with that, you can get severe acidosis as well, just again with that imbalance with the respirations. If an animal has suspected epilepsy, then you want to, as an RVT and the veterinarian as well, would discuss risks versus benefits of daily anticonvulsant drugs, because of course all drugs definitely can come with their side effects, which we'll talk about. And if it's an equine or a cow, so something that's a very large animal, in reality, if they have epilepsy of any form, then it's most often euthanasia, because realistically, for them to have a seizure, it's extremely dangerous to them with their physical body weight, and also extremely dangerous to people as well. I just want to make one more point about the severe acidosis here as a result of convulsions. Acidosis can occur with sort of respiratory acidosis, but also it's important to note that with the continuous contraction of the muscles, they can get a buildup of lactic acid, which of course can shift them into an acidotic state. So when we're talking about anticonvulsant drugs, we are not talking about a cure for epilepsy. That's not what the aim of the game is. The aim of the anticonvulsant drug therapy is control, not cure. So unfortunately, we can't cure epilepsy at this stage in our profession, but we can look for various methods of control that are appropriate for that specific animal. So we're going to work our way through anticonvulsant drugs. There are a variety of them, but it's not too many comparatively to other classes of drugs that you guys have worked your way through. So we'll start it off with the most common anticonvulsant drug, which is phenobarbital. And I should clarify that this is the most common outpatient drug. So this is the one that we're going to send the animal home with for medication and control of their seizures. Phenobarbital is a barbiturate. So of course, what that means, it's a recordable drug. It's a controlled drug. So the RVTs have to be very, very careful to ensure that they are recording them as they're taking them out of the locked cabinet. This is generally the drug of choice for long-term oral dosing in dogs and cats, and it decreases the likelihood of spontaneous brain cell depolarization. It also slows the spread of depolarization. So even if a couple of those neurons start firing, it's going to slow that spread, which essentially is what the seizure is made up of, is that continuous sort of discombobulated spread of depolarization across the brain. This drug increases the effect of GABA, which has a calming effect, and it allows chloride ions into the cells, which of course results in the cell being less likely to depolarize because it's now shifting it to a negative, maintaining that balance on either side. In general, phenobarbital has a fairly long half-life, so generally we give it 1 to 2 times a day. And this is something that, with regular monitoring of blood work and monitoring of patient symptoms and side effects, it is something that a lot of animals are on for life. However, there are negative side effects that we, of course, have to discuss. So about those negative side effects, there are a lot of potential negative side effects. So number one, it can cause polyphagia, so an increased eating behavior, polyuria, polydipsia. It can cause an increase in metabolism of many other drugs in the liver. So unfortunately, what can happen over time is animals get used to their doses of phenobarbital in a way, or they develop a tolerance of doses of phenobarbital because of this enzyme induction. So in the liver, when we give an animal phenobarbital, the liver starts to increase the production of a number of their enzymes within the liver. And within that, it naturally, biotransforms phenobarbital. But unfortunately, the presence is induced by phenobarbital. So these enzymes, they come about when we give phenobarbital. They're good because they biotransform phenobarbital and allow the body to utilize the drug. But as we continue to give phenobarbital, we continue to produce those enzymes. So what ends up happening is over time, they, air quote, get a tolerance for phenobarbital because these enzymes in their liver are just eating away at the phenobarbital faster and faster because they continuously are producing these enzymes. Unfortunately, this can also affect other drugs. So there are many other drugs, ones that are metabolized by the liver, that when we are giving them to an animal who's on phenobarbital, we have to be very much aware that there's potential that they will get metabolized faster than they would if the patient wasn't on phenobarbital. So it's kind of frustrating, and quite often what they find is over time, patients end up getting breakthrough seizures. So what that means is that they've been regulated for months and months, they're doing really well, and then all of a sudden they have a seizure. And nothing has changed about their phenobarbital dose at all, like nothing. So what that is, of course, is the enzymes have metabolized the phenobarb faster, and the animals now developed a tolerance to it because of that. So they end up needing an increase in dose or an addition of another medication. There's wide individual variance in these effects with phenobarbital. In general, with the effectiveness of phenobarbital, every animal is slightly different. Definitely, there's an initial phase of sedation, and it can certainly be hepatotoxic with long-term use as well as with high levels of use, so high doses. The initial sedation, just going back to that, that's a tech point as well, an RVT point when you're administering this drug to an animal or you're sending it home with an owner. Super important to note and let them know that the sedation can last 2 to 3 weeks, and then it should start to go away for sure. Adjusting the dose may precipitate seizures. So if an animal, if the owner would like to reduce their dose, then it gets really tricky because there is potential that they could have a seizure because of that. And then this one is also about 50% protein bound, so we have to be cautious with hypoproteinemic patients. Because of course, if we're giving them a regular dose, but they have a low level of serum protein, then there's going to be more of the phenobarbital entering into their general circulation as opposed to staying within their vasculature attached to those proteins. All right, also with this too, the cat dose is about 50% of the dog dose, so just something to keep that in mind. And then hyperactivity, like as if we can't have enough negative side effects here, some animals get crazy hyperactive on phenobarbital, and in that case they have to change meds. So this is really important from a technician point of view, because you guys are the ones that need to have this conversation with the owners. You're the ones who end up calling the owners regularly, typically every 3 to 6 months. We need to do blood work. And those are all considerations for the owner prior to starting them on these medications. Can they afford long-term medication? Can they afford regular blood work, like very regular blood work? And what if the animal develops a tolerance and we have to add an additional medication? Can they afford? Can they maintain that with their lifestyle? And with the blood work, what we're checking, it's not just, baseline. We're checking phenobarbital levels in their blood. And we're also doing typically a full liver panel as well, because we know that over time it can become hepatotoxic. So it's certainly a very common drug. It's sort of the best option that we have for patients who have regular ongoing seizures, but it shouldn't be taken lightly. It's a drug with a lot of potential side effects. Also with this, I was going to say 1 grain is 60 milligrams. So it just depends. Most often now, I find that they're measured in milligram sizes. Phenobarbital used to be very much based on the grain system of measurement, but I don't think you really need to worry about that so much anymore, because now we're looking at 15, 30, 60, and 120 milligram phenobarbital tablets. So here's a little chart for you guys. It's a barbiturate. Phenobarbital, most often, oh shooty, of course I forget the name of it. Here, it's right here in my other PowerPoint. Epifen, sorry. So the trade names in Ontario, I would say the most common one is Epifen, Epiphen, and that's fairly new to my clinic, so that's why I added it in there most recently. And some people also get phenobarbital compounded from a compound pharmacy as well. Mode of action, it binds to GABA receptors and blocks the AMPA receptors, so it creates that reduction in that depolarization wave. Positive effects, number one choice for long-term seizure control, has a long half-life, so we can typically get down to 1 time a day, which equals greater client compliance. And then, of course, there's a lot of side effects that we just went through. Okay, diazepam. We've talked about this one before as well. So this one is a benzodiazepine. So what you need to know from that, of course, is that it's a controlled drug and we need to record it when we use it. It is a drug that is our most common drug for emergency use. So when we have a patient who's actively seizing in clinic, benzodiazepines and diazepam specifically, the injectable version, is the number one go-to. It enhances the inhibitory effects of GABA, which again has a similar effect to phenobarbital in that it slows that wave of depolarization and creates a sedated effect. Has a very short duration of action because of the first pass effect, and also for this reason, we don't give it orally. So this one in particular, we're not sending home diazepam to patients. It undergoes a significant first pass effect. And then I was going to say something else about that. I'm going to leave it at that. So it's best for use, immediate use in status epilepticus patients. Long-term seizure control, again, we're not going to use diazepam, so we tend to switch drugs. Most often, we're trying to give this intravenously if the patient's in clinic. Otherwise, it can be given rectally and even transmucosal. So with this, one thing that you might note is it will go home with clients not so much in an oral format, but we might draw up their emergency seizure dose in a syringe, send it home with the client so that if the patient has a seizure, within the next couple of hours or within the next 10 to 12 hours, then they could potentially give the diazepam rectally through a syringe without a needle. So that's an instance that you might see it. It is light sensitive, so we have to wrap it up in vet wrap, the syringe itself, when we send it home. And then some people have talked about using diazepam as a CRI, so a constant rate of infusion for status epilepticus patients in clinic. There's challenges with this. It doesn't mix well with others. So one of the rare things or the only things that diazepam can mix with without causing precipitates is ketamine. So we get Ket-Val, which is stable, but we're not going to use that in this situation, just saying that it's one of the rare substances that diazepam mixes well with. But otherwise, like saline, lactated ringers, all of that, we have to be very careful because diazepam doesn't always like to mix, and it can cause these precipitates within the line. Likewise, Valium can stick to plastic, so in the IV line itself, and develop little precipitates, which are little, essentially like crystals of drug within the line. So it's not ideal. It is possible to be given as a CRI, but it's really tricky. So we have to flush the IV line with Valium to coat the line before we use it as a CRI to ensure that the Valium itself isn't sticking to the line. It's not ideal. Sometimes we have to use it and we don't have much of a choice. Cats, when we're talking about cats with diazepam, they have less ability to metabolize and it can cause longer term liver failure with cats. So there is potential long-term use with cats and dogs that it can become a challenge to the liver and cause liver issues. But cats in particular are quite sensitive to that. So we don't often give cats diazepam on its own. We can in the case of an emergency, but it tends not to be quite as effective for cats in regard to seizure control. The effects of diazepam on behavior, so just in general, not just cats, but overall behavior. Generally, these animals, once they've received diazepam, they're pretty sedate, they're relaxed, and their muscles are relaxed, which is a massive benefit because if you have a patient who's seizuring, not only will this work with GABA, stimulate GABA to create that sedative type effect in the patient, but it's also going to act as an actual muscle relaxant too. So those rigid muscles can finally rest. It's also an anti-anxiety. The trick here is we have to be careful because it could unmask unwanted learned behaviors. And in truly aggressive animals, we have to be very cautious and they technically should have a basket muzzle on because there's a lot of bite potential. So once we take away those inhibitory reflexes, then, we could be risking a bite for ourselves. So looking at diazepam, it's a benzodiazepine. Known trade name, of course, is Valium, and then there's a whole bunch of different names for it in clinic. So it attaches to GABA receptors to enhance the effect of GABA. It's the #1 choice for status epilepticus, muscle relaxation, seizure inhibition, safe for cardiac and respiratory patients. So that's really nice too. If you have a patient that just, gets rushed through the door, they're having a seizure, the vet grabs the diazepam, even if that patient is a cardiac patient or a respiratory patient, we know that diazepam is pretty safe for those patients. So it's kind of nice in that way. Side effects, it's pretty short acting. It does undergo the first pass effect. Cats are less able to metabolize, and long term, they can get hepatotoxicity. Caution with bite potential, and it doesn't really mix well with water or other solutions. Now, for giving diazepam, I added deep IM as well to this slide. So typically we give it intravenously or transmucosally or rectally, but you also can give it deep IM, but it has to go extremely deep in the muscle. So we tend not to. We tend not to go there. All right, moving along in seizure control or anticonvulsant drugs, we have bromides. So bromides are kind of a weird one. They're a chemical reagent. So it's a bromine bonded with another element. So typically we're looking at a sodium bromide, potassium bromide, or ammonia bromide, which is compounded into a liquid with water or corn syrup. So these are agents that we order from a compounding pharmacy. And most often we're talking about potassium bromide. So KBR down there on the bottom right. Mechanism of action is interesting because we don't entirely know how it works, but it acts like chloride, or sorry, it acts like chloride ions to change the resting membrane potential of neurons. So it causes this overall effect in the brain that causes a decrease in depolarization, which is, of course, decreasing the chances that the animal will undergo a grand seizure. So not entirely sure how it works, but those are the effects that it seems to have on the brain. Very interesting. Has a long half-life, which is also very interesting. So 21 to 24 days. And the loading dose, it does have a loading dose as well. It increases the plasma concentrations of the drug to get it up to that ideal level. And then in a steady state, it takes 3 to 5 months to get there. So very interesting. We give it a loading dose. We give animals a loading dose with this. Typically, we're using this in dogs only. But it takes 3 to 5 months to reach a steady state in the blood. So with that, it's super important that we tell the owner that it can take 3 to 5 months to see the full effects. And within that time period, we're going to be completing some blood work. And of course, after that time period, we have to complete blood work as well. That's a very, very long time to get a steady state in the blood. So looking at bromides, potassium bromide, we're using on dogs only. It's not the first choice of medication for using for anticonvulsants. It's for animals who can't have phenobarbital or for animals who are at their max with phenobarbital and are starting to get breakthrough seizures. And that's the case that I've seen it pretty much exclusively in my career in vet medicine, is when an animal starts to get breakthrough seizures on phenobarbital, then potassium bromide is introduced. And it can be used alone, of course, or with, as I just said. So this is why we don't use this as the immediate go-to as our first choice. So potassium bromide has a really narrow therapeutic index, which of course means that the dose producing therapeutic effects is really close to the dose causing toxicity. So it's really scary. And if a loading dose overshoots the therapeutic range and produces toxicity, it means that these side effects are going to be there for hours to days, right? Because it has a really long half-life. That being said, too, we know that it takes 3 to 5 months to get to a steady state within the bloodstream. So again, if we realize 3 months in that we've been giving that sort of borderline therapeutic / toxic dose, then the animal can have some pretty serious side effects long term. So it's not really the best. It's actually a little bit scary. So again, you're not going to see this as the main go-to for anticonvulsants, but you're going to see this as an adjunct therapy when other options are not available for various reasons. Potassium bromide, also vomiting, really interesting, causes vomiting almost exclusively. So vomiting can occur, and it often does occur in dogs, even if the dose of potassium bromide is within the acceptable range and within the therapeutic range. And it appears to be a direct effect of the salt on the stomach, which produces a local gastric irritation. Overall, vomiting can be reduced a little bit by using a liquid formulation instead of a capsule and by dividing the dose into 2 or 3 times daily doses. And you can try different foods to be given with the potassium bromide to see which one tolerates the best. So it's, again, This is a client conversation. This is an educational conversation. Hey, vomiting may occur. Please let us know if it does. We can offer you some tips and tricks. So this is a big one, and in general, I guess it's not just potassium bromide, it's all of them. So all of the anticonvulsant drugs have a lot of side effects or have a lot of potential side effects available when we're giving them to patients. So our role as RVTs is to discuss the clinical signs. So what is normal? Oh, that's right. They're going to be sleepy for the next 3 weeks, potentially. What is abnormal? Oh, he's continuously vomiting. Should I have called the vet? Going through all of this with them ahead of time is really important in the success and the likelihood that they'll have compliance. Encouraging regular blood tests, and I highly, highly recommend as an RVT to take the extra step and print them out an estimate for the first year. So print them out a projected estimate. These are the drugs. This is the likelihood of how much drug your animal will need. And this is an estimate that includes the drugs, the supplies needed to administer the drugs, and then all of the blood work that we're going to need to include within that first year. It's really, really important that they have a heads up for that. Discuss potential for breakthrough seizures and what those look like, and always, always discuss the side effects. By discussing the side effects as well, there is potential that you can get a little bit more compliance with the owner in regard to regular dosing and in regard to doing that blood work when the blood work is recommended. So again, just highlighting this, RVTs, you guys have a pretty mega role in creating a successful anticonvulsant drug protocol for your patient simply by talking to the owner and letting them in on all of the ins and outs of these treatments. So potassium bromide, it's an anticonvulsant. It's an oral dose. K-Bro is in the vet, or sorry, K-Bro vet is the USA, which really cracks me up because I can just picture it in California, like K-Bro. I don't know why, every time cracks me up. So I think that's a US only because I haven't seen it up here. We generally get potassium bromide compounded because we want it in the liquid format. Mode of action, they're not quite sure. Similar to changing that negative versus positive within the cells to prevent depolarization. Positive effects that can be used in combination with phenobarbital and less frequently given. Side effects, it can take weeks to months to find that ideal dose. Dogs only, sedation and ataxia are not uncommon. Close monitoring of blood levels, and of course, vomiting can occur as well. All right, moving on to zonisamide. So I'll talk about, I think I've got coming up a few different drugs that we can use as anticonvulsants. And again, so remembering that phenobarbital is number one, but we know that a lot of dogs and cats can potentially get breakthrough seizures with phenobarbital. So this is where we start getting into the other drugs that are available. So zonisamide is very expensive, and it's a sulfonamide anticonvulsant drug. It affects the sodium-potassium channels in the neurons in the brain, again, to help prevent those constant waves of depolarization. Again, it's very expensive. It's often started when phenobarbital is no longer working, or if they're having issues with phenobarbital, then we start to get into zonisamide. Carrying on, Keppra is fairly common. It's for animals that are reactive to phenobarbital, or it's as an adjunct therapy with phenobarbital. We give it every 8 hours, and it has a high level of safety. Propofol can be used in refractory seizures. Generally, we don't use propofol. Some people use it as a sort of a stat treatment for that continuous seizing patient where we're no longer getting an effect from the Valium that we gave. So that's the case that I've seen it, where you simply need the patient to be unconscious so that their body can rest for just a few minutes to, avoid hyperthermia, etc. Of course, downfalls with propofol, we've got potential for apnea, potential for decreased arterial pressure, and potential to cause seizure-like activity, oddly enough. That's more also too, we get like a twitching with propofol sometimes when given on its own. Klonopin has low bioavailability and a high frequency due to the bioavailability. So it's not, in its clonazepam, it's not the most ideal, again, because of first pass effect. It tends to have low bioavailability. So the owner tends to have to give it in multi-doses throughout the day. Not ideal. And then gabapentin was historically used as an anticonvulsant, as a form of a glutamate blocker. So now gabapentin I find is really not used as an anticonvulsant, but it might be something that is used in a complementary fashion. So not used as primary control. So looking at all these drugs, I had a friend, of course, who was an RVT, and she was fostering this sweet little French bulldog, like nicest little bugger in the world. And I'm pretty sure that French bulldog was on phenobarbital. Pretty sure now, I could be wrong. If she sees this, she'll correct me. But phenobarbital, potassium bromide, Keppra, and zonisamide, because that dog kept having breakthrough seizures. And there was no tumor. It was an idiopathic epilepsy. So again, it's a long road. It can be a long road. I'm going to loop back to my PSA about pet insurance. And this is why I think having pet insurance from the time your animal is young, so puppy or kitten, can save you so much stress and financial grief in the end. And I'm a really strong believer. But either way, treating seizure disorders, seizure conditions is a long road. And again, I think that being able to work with the client to let them know that you are along that long road with them, you are there to help them, you are there to support them, can really foster that sense of connection in the end. And it can really increase client compliance because it's not an easy road for them to go down. Thank you, everybody. That is it.